appreciate that. That's going to be really good. She's excited, and I'm sure she's going to get funded because she was funded once, and her proposals are very well written.
Yeah.
We ready to go?
Alrighty. I have the honor of introducing Dr. Michele Saunders, who is my fearless leader here. And she is the director of the South Texas Geriatric Education Center, who has sponsored this whole shindig for the week. And she has a lot of other titles, and
we'll skip them.
Okay, so Dr. Saunders.
So how's it been going this week? I know this is we don't call it the summer intensive for nothing, though we've tried to lighten it up a bit and we call it the Summer Institute now. But has it been a good week?
Oh, it's been great.
You think it's been great? Because, you know, we've missed this part of our education, all of us, for a lot of years, and it's good to finally catch up with it and to get some credit for it and, you know, to get to eat a little, to visit a little. It's a nice opportunity because there's a variety of folks here. I guess what I've been elected to do today is give you the aging eye, and let me have an instant disclaimer here. I am not an ophthalmologist, nor am I an optometrist or even an optician. So what you're getting is hopefully more than what you know. And obviously, I am a geriatrician and a dentist, and I've had some training, so that should help a lot. I don't think it'll disappoint you. Okay. The most important thing that everybody in this room already knows is that regular eye exams are vital. And as we age, they become more and more important. In fact, a number of the disorders that I'm going to show you are age-related. And because of that, it's important that every 2 to 4 years, once you hit 40, how many of us in this room are over 40? There are several. You should be going to the at least optometrist, if not an ophthalmologist, every 2 to 4 years after 40. And once you hit 65, it's every 1 to 2 years because your risk goes up that much more for having one of these major disorders. So exams are vital. Okay, what we're going to address today is just these 5 major conditions that are age-related: presbyopia, cataracts, glaucoma, macular degeneration, and diabetic retinopathy, though I've ordered the last 2 inversely. We'll do diabetic retinopathy first. This is the eye in normal vision, okay? So you see the light coming in through the cornea, through the pupil. You see the iris there, okay? And it goes and focuses, because of the lens behind the pupil, on the back of the eye, directly where it's supposed to. That's normal vision, okay? If you look, also, you see the retina in the back. We've all had this. This is just like rehash so you don't forget. There's a choroid membrane behind that, and a sclera, which everybody knows is the white of your eye, but the conjunctiva actually covers, as you can see in the front of the eye, the cornea, all right, as well as the outside lining of the eye there. The ciliary muscle, we're going to be talking about that briefly, and you can see that it's attached to the lens of the eye. Okay, everybody see those? Right? One up here, one down here. Okay. We're going to be talking later about this area right here, which is an angle that we hope is open, and there's a reason for that, and we'll discuss it in a little bit. Okay, normal vision. This is what happens for close vision and distance vision in the normal eye, all right? You can see that the ciliary muscles up here are nice and loose. Oops, didn't want to do that one. Are nice and loose. Come back here, arrow. There you are. It's so nice to not have a laser pointer. Right here. And that the lens is elongated, okay? So that's what your eye is supposed to do for distant vision. When you want to look at something close up, your ciliary muscles contract and that means that things get loose and the lens shortens to a little more round shape, which focuses the light right where it's supposed to be on the back of the retina, so you can actually see what you're looking at close up. And as you had a brief intro to here, presbyopia, once you hit 40, it's all downhill, folks. Short arm syndrome, okay? And you can see people who lose that ability to focus near and far vision quickly. I have to read this. It goes all the way out here so I can read it better. Some of us who are extremely nearsighted do this instead to read, or this, and we're unusual. Most people hold it farther and farther away, and that's what reading glasses with magnification are all about. How many of you here have reading glasses? Okay. Okay, so presbyopia then is an age-related condition where the eye absolutely loses that ability to focus on objects that are closer. 90 million people have it or are going to have it by 2014. 90 million. How many people are in the entire country? That used to be in the entire world. Now it's just China, 3.6 billion. I think we have something like 350 million people now in the United States. 90 million of them, that's a significant number, are going to have trouble reading. What does that tell you for what you're going to be doing in the future? When whatever job you go out to do from here, or that you already do, and you want to hand some old person something to read, it better have what? Big print. Now you know why they need big print. Okay, so we know that there are really two things going on here as causes for presbyopia. One is that as we age, our lens becomes less elastic. We need it to be thicker for near objects, thinner for far objects. It loses that ability, okay? The second reason is that the ciliary muscle that's working really, really hard to try to compensate for this lack of flexibility in the lens finally gives up because it gets weak. Genetics. People who have presbyopia in the family are more likely to also have it. And this I found very interesting in the literature. If you are stressed, your stress will impact the rest of your body in all sorts of different ways. And one of them is that you're more inclined to be presbyopic. Personality type, that goes right along with stress, doesn't it? If you're a little bit more laid back, you're less likely. Oh, there's not a student alive who's laid back. And diet. You've heard a lot about vitamins for the eyes lately, right? Well, guess what? That's based on sound research. And when we get farther down the list of diseases, I'll actually address some of those nutritional issues for you as well as supplements. So how do you know you've got the problem? When you're trying to read something up close and it's blurry, and you can tell you're looking up and then you're looking down and you can't make the adjustment fast enough. A lot of folks will actually get headaches when they're doing close work, and their eyes will just feel tired from doing it because they actually are not compensating. So they need to go ahead and do a few things. And of course, once you hit 40. So how do they tell? Obviously, they do a refraction on your eyes to see whether the light goes to the retina, where it's supposed to go, when it's supposed to go there. Also, a visual acuity test, which we all know about, the eye charts, ability to see those charts, whether you're close up or far away. And how they judge that is the size of the print on the eye chart. And of course, whether your eyes are coordinated. And they can tell that obviously by moving an object around and having you follow it. That's one way of telling if your eyes are coordinated. If they both go at the same time, that's a good sign. And of course, that shows that you have good muscle control as well. And of course, whether or not you can change focus. So up until recently, the only cure was no cure. It was just a treatment, and that's glasses. Everybody knows about glasses. Well, bifocals, trifocals. There are even glasses now for computer use. There are people who have trifocals, and I don't know if they're fourfocal, but they actually have another pair of glasses that's strictly for computer use, because you're a little bit farther, you're supposed to be from the computer screen than reading distance, and you don't want to use your distance vision, which would be right out the center of regular bifocals, so they come up with these one more pair of glasses to wag around with you. And they also have monovision contact lenses, modified monovision contact lenses, and bifocal contact lenses. Who knows what monovision contact lenses are? Because I haven't. Go ahead.
You see distance with one eye and close up with the other eye.
Exactly. Monovision contact lenses, you have one eye corrected for distance vision and one eye corrected for near vision. And they determine that by deciding which is your dominant eye. And modified monovision, they actually have one eye that's a bifocal and the other one that's strictly for distance. And there's less thought about whether you have to switch eyes to read. I'm telling you, it's amazing what you go through trying to see. And then, believe it or not, they now have surgery for people who have a hard time seeing up close. Good self-care is important, and those are things like not straining your eyes, reading without appropriate lighting or magnification, and complementary and alternative treatment has become very popular, and we'll talk about some of those. And I have allergies, and I'm taking antihistamines and have a dry mouth, so I'm going to keep drinking water if you don't mind. So, surgery. There are different kinds of refractive surgery. There's conductive keratoplasty, laser-assisted in situ keratomyeleusis, or LASIK, laser epithelial keratomyeleusis, or LASEK, photorefractive keratectomy, or PRK. And some of them are used for different problems depending on why it is you can't see up close. And some of them are used if you're farsighted, some if you're nearsighted as well, some just strictly for having presbyopia. And they also, of course, have lens implants. And we'll talk about that when we get to cataract surgery, but they have lens implants now that even correct for presbyopia. It's marvelous. Okay, so we talked about the fact that you have to have regular eye exams, and by all means, please wear the right prescription, except when you're wearing sunglasses, because it's so expensive to keep getting another pair of sunglasses that are prescription. Okay, control chronic health conditions. This is important. Diabetes and hypertension impact your eye health, not just in diabetic retinopathy, but in things like presbyopia as well. Know symptoms and how to recognize them in yourself, which is always a trick, not to mention your patients. And be careful about UV radiation from the sun. It does affect your eyes. It's believed, and some of the research says that they think there's a very strong correlation between UV radiation and cataract development. So that's important to know. And healthy eating in terms of diet, fruits, green leafy veggies, antioxidants are key, vitamin A, which is beta carotene. And I did mention good lighting as vital. Okay, so there are other things you can do, and those are called visual improvement therapies. And I'll show you a slide, I think, of one of those. Nutrition supplements that are notorious, that you've been seeing in all the ads on TV and so forth, they come out of the research just in the past 2 years, that's how new. Lutein, zeaxanthin, vinpocetine, L-lysine, and vitamins and enzymes. And the vitamins, of course, are always the antioxidants. We've talked about lifestyle changes. Okay, so we're all stressed. What is it that we have in our lives that can break stress for us, even if we're a student and we're studying for exams? What can break that stress for you? Taking periodic breaks. What else? Exercise. Ooh, I love this group. What else? Proper nutrition, which is really hard. My daughter happens to be a sophomore, just finished her sophomore year at UT Austin, and I've never seen anybody eat worse while studying. I mean, I even wagged myself up there with bunch of boxes of nutrition bars because I was so worried about her and her roommate and their bad eating while studying for exams. How can you think if you're not getting adequate nutrition? And of course, you're staying up all night. How many stay up all night while studying? Oh, I love it if you don't. I'm so proud of you. But the rest of us, you know, what can I say? I was up practically all night working on this lecture. So, you know, pot is calling the kettle black here. But what that means is if you're going to do stupid things, one needs to learn how to cheat intelligently, okay? And that means the spiritual part of you is important, okay? Whether it's exercise, whether it's listening to music, whether it's dancing around your room, whatever it is you love to do, do it. At some point, when you can take a break, okay? Now, there are some really cool things out there that ophthalmologists and optometrists recognize, and they are visual improvement therapies to avoid glasses and reading glasses for presbyopia. And there's a DVD that does it, and there's something called Rebuild Your Vision program. You can find these on the internet. They cost, but they're relatively inexpensive. I think the Rebuild Your Vision program has a whole bunch of exercises, a DVD, things you can print out, and it's, if I'm not mistaken, $47, which isn't too bad. And there are eye exercises that you can do for your own eyes with things like acupressure and pressing on areas that will give you some relief from eye strain. So, and cold, putting cold on your eyes. Those are all important things that make a difference. We're going to talk about cataracts next. That's a cataract, in case you didn't recognize it. How many have an old dog that has cataracts? So you've seen that one before. Okay. Cataracts is one of those other age-related conditions where the lens of the eye gets deposits in it. It's made of protein. These proteins aggregate, they clump, it starts little and gets bigger. And what happens? You can't see sharply or clearly because the light is now scattered around all of these particles. It is the leading cause of blindness through the entire world. So we're talking 17 million people. That's 50% of all blindness is caused by cataracts. And half of those folks over 80 have cataract. It used to be that cataract surgery was major and you went in the hospital for it. And everyone thought, oh my goodness, you're old, you can't handle going in the hospital and having a surgery. Well, one thing about having good technology in this country and quality medicine is that over time things sometimes really improve, and one of them is cataract surgery. It's now often outpatient, and you can be really, really ill and do great with cataract surgery. The number of people, we're talking 17 million in the world, it's going to go up to 34 million in 3 more years. We'll have cataracts. Okay, we talked about the fact that the lens is made of water and protein, and that's arranged in a precise way so that light gets refracted through it just so it comes to a pinpoint place on the back of the retina and keeps that lens clear. Well, some of that protein clumps. We talked about it starts to cloud the area, but it gets bigger over time. And then you get blurry and foggy. UV light we talked about. That's pretty much proven. Cosmic radiation is one of the newer theories that needs more research. They're expecting a lot more pilots and astronauts because of cosmic radiation to actually come down with cataracts more than the other population that doesn't fly. People with diabetes, there seems to be a connection. They're more likely. It's a risk factor, but whether or not it's a definitive, oh, they're going to get it, that requires more research. People who are on heavy doses of steroids for a period of time, diuretics, oddly enough, and major tranquilizers. What are major tranquilizers? Phenothiazines, right? What are some of those? Mellaril, Haldol, those are some of the brand names. And it used to be that older people in nursing homes were managed by being given those medications, because nursing homes are understaffed, and there was a time before nursing home reform law went into effect that it was, let's just not have any personality showing here because we don't need anybody to be difficult, we just need to get our jobs done. So they would chemically sedate people. And all those folks over time, if they live long enough, would develop cataracts. And more research is needed on cigarette smoke, air pollution, drinking, and lead exposure. Some research is indicating yes, but not enough. Just because you've got a handful of studies doesn't mean that's really for sure. So there's more research being done there. There are a couple of different types of cataracts. One is nuclear and the most common. Okay, that's the center of the lens. Cortical, the cortex of the lens, is the outside part of the lens. I'm not talking about the sac or the capsule that the lens sits in, but the actual part of the lens itself. That's the kind diabetics seem to get most. And subcapsular, which is actually in the back of the lens, also common in diabetics, but people who have far-sighted eyes, retinitis pigmentosa, or on high doses of steroids tend to get that as well. So we talked about the fact that it starts little, and little effect on the vision in the beginning because it's just a little bit blurry, like looking through a clouded piece of glass, all right? And we all have, I don't know if you've heard about this, but there's a lot of controversy right now called, did Monet have cataracts? And of course, light is glary for you. You see a lot of glare, and headlights are not a good thing. Colors are not as bright. A lot of people start getting blue, yellow, blue, and green colors distorted because what happens in cataract is the lens also yellows, so it adds a yellow tint to everything you're looking at, and that tends to alter colors. This is what you pretty much see if you have cataracts. It's like me without my glasses. The nearsighted view, only it's more cloudy than just not clearly able to see it. Here's another one that's really good. And I think the thing that's the best about this is that you can see this is the normal eye, how that light comes through, this beautiful, nice lens here, focuses it all right back centrally to pinpoint right where it's supposed to go on the retina, and you see great. Well, here we've got all this particulate matter in the lens, and the light breaks up around it, and that's why everything's cloudy. Isn't that great? Good slides. Okay, so early treatment for cataracts, what they do is, okay, we're going to max out your vision by giving you stronger prescriptions all the time, and magnification, and good lighting, and then eventually quality of life gets so impaired because you're afraid you're going to fall and all these other things happen that it's time to do cataract surgery, in which they remove the lens and then replace it with an implant. It's the most frequently performed surgery. That's kind of interesting. More cataract surgery than anything else. 1.5 million cataract surgeries a year, and you get really good results. 9 out of 10 get 20/20 to 20/40 vision. So the first thing they do is microincision. Then they do capsular hexis, which is incision of the sac in which the lens sits. They do phacoemulsification, where they actually break up the cataract ultrasonically, and then they aspirate it out. After that, they stick in to the nice sac that remains this foldable intraocular lens implant. This is what they would do for the incision. And then, I don't know if you can see that very well, but right here, this is the capsule on the lens, and they've made a slice, and they're lifting this piece up so that they can slip the lens out or begin to phacoemulsify it. So now what they're doing is they've got this instrument, and this little tool here is holding that flap that they cut away from the eye, and they're in there cutting up, and they'll do another cross section of it to be able to break that lens up into sections, and they'll start sucking it out right there, okay? Aren't they cool slides? And they irrigate as well, so you make sure they get all the pieces, because you don't want to have a single piece left behind when they put in this fabulous new implant lens, right? And they leave a crumb behind. It's like leaving a piece of gauze in, you know, to major surgery. You don't want to do that. Okay, this is what these really cool intraocular lens implants do. They have distance driving areas, distance vision in low to moderate light conditions, distance vision for daytime driving area, near vision for full range of light conditions, near vision for moderate to low light conditions, zone transitions for intermediate. I mean, it's unbelievable what these things can do now. And then they fold it up and plop it in there. Lay down the flap, and it's sitting in there, the little spring. See, the little spring is now compressed to hold it in place. This is what it looks like from the side with the little springs. It's so neat. Okay, so this is what 20/20 vision means for those of you who don't know. That means when you stand 20 feet away from something, you can see what the normal human being can see clearly. Okay, so people at 20/20 don't need glasses. Most people who have this kind of implant don't need glasses. People who have diabetes, however, can be slow to heal, they can get an infection, and the most important issue is glycemic control. You've got glycemic control, you don't have to worry quite as much about how well someone's cataract surgery is going to go. Okay, glaucoma is next. Everyone knows that glaucoma is basically about elevated pressure inside the eye by a buildup of excess fluid, but a lot of people don't really know why, so we'll talk about that a little bit. And unfortunately, what we don't want is for it to damage the optic nerve, because it can, and it can lead to blindness if it's not treated. So sometimes people don't know they have it, which is another one of those reasons why, as we get older, it's very important we start making sure our routine visits for eye exams happen. What happens in glaucoma, the damage that's caused is peripheral vision loss. So that means people can't see anything out here, right? That becomes a problem. Glaucoma, they call the sneak thief of sight, because people really don't know that they're losing their peripheral vision. So then what does this tell you need to do every once in a while? Go your eyes around and look and see if you can see everything, all right? If you see, gee, could I always see that far? Or couldn't I see farther than that? It's important, okay? There are two kinds of glaucoma. Primary glaucoma is open angle. The cause is unknown. We don't know. And I'll describe what the difference is between open and closed angle glaucoma in a minute. It's actually an anatomic, really important issue. And secondary, we kind of know what's caused it. Eye disease, eye deformities, injury, medications are some of the things. And then there's low tension glaucoma, which is very poorly understood. These are people who have normal pressure in the eyeball, but they still get eye damage. One of the theories is that the atherosclerosis of the blood vessels coming to the eye are actually causing a starvation of the nerve, and that's one of the reasons that they think it occurs. So this is what you see if you have glaucoma. That's pretty far advanced, okay? You can see in the middle, but you can't see around the edges. So you'll find with older people, it's hard to tell. It's pretty hard to tell if someone's lost their peripheral vision. They're just turning their head to look at things maybe more, but you don't particularly notice it. There are a number of diseases that can lead to glaucoma. because there's more than one type. It's another leading cause of blindness. There are 3 million people who have it, and remember I talked about it as the thief of sight, because half of those 3 billion don't even know they have it in the United States. It's a lot like diabetes in some ways, right? Diabetics, half the population who has it don't know they have it. African Americans over 40 are at the highest risk. People over 60, especially Mexican Americans, are at risk. Those with diabetes are at risk. Those with a family history of glaucoma are at risk. And people who take steroids, and there's one study out there that says that people who use coffee regularly, take coffee regularly, are more inclined and at higher risk to have glaucoma. But I want to see more studies before I believe that one. Okay, so we know elevated eye pressure. We know that that's a risk for glaucoma. There are some people who have elevated eye pressure who don't have glaucoma, but they're at higher risk. People who are farsighted are at higher risk. So are those people who are nearsighted. Apparently, if you've got perfectly normal vision, you're okay. Past eye injuries put you at higher risk. History of migraine headaches. I thought that was very interesting. And I would imagine it's more than the occasional once every 10 years kind of migraine headache. People who have them often are at higher risk. And of course, hypertension, coronary artery disease, and hypothyroidism, oddly enough, also put people at risk. Structural abnormalities. There's something called pigmentary glaucoma where the iris sort of sloughs off little pigment granules and they go into the aqueous and vitreous humor and create increased pressure, which is kind of interesting. 80% of people who have glaucoma have something called open angle and 20 have closed angle. And the causes of open angle is, or are, that the aqueous humor, you know, everything is a cycle in your body. You've got all sorts of exits for stuff to get out. Well, your aqueous humor drains out of your eye as well. And it comes out through the anterior chamber of the eye, and I'm going to show you where and how in a minute, but it's very slow. And that's called open angle glaucoma. Fluid, therefore, builds up, and then you end up with an increase in pressure. That's how the open angle glaucoma occurs. So ultimately, over time, it damages the optic nerve and can obviously damage other parts of the eye, and you lose peripheral vision. So what you're seeing here, this is the normal flow of your fluid out of the eye, okay? You can see the lens and the ciliary muscle, okay? So it flows out there around the eye like this, on both sides, through the ciliary muscle, behind the iris. There's the iris right here, okay? And then comes out through this little spongy trabecular meshwork right here. And this is what it is. This is the iris, okay? And here comes the fluid, and it gets up to this trabecular meshwork right here and comes out through Schlem's canal, which is an interesting name, Schlem. Okay. And here's a really good drawing of it so you can see. So here's the anterior chamber of the eye, and here's the ciliary muscle, and the fluid comes out here behind the iris, comes down around in front of the iris, behind the cornea, in front of the lens, and goes all the way up here, but uh-oh, there's something wrong with trabecular meshwork, and it's forced back. That's the open angle right here, okay? What they mean by open angle is there's a space between the iris and the back of the cornea where the fluid can go, all right? But it's still stopped by a problem here with the meshwork. So it backs up, and that's how you end up with the high pressure. Most people don't have any symptoms. That's why it's the thief. Half don't know they've got it. And what you see, you don't always have just a big blob like you saw in that slide of blackness in the center of your vision. Sometimes it's just blank spots. The more severe the damage, the more the number of spots, or they eventually coalesce and you get a big one. One thing that's very rare is called closed angle glaucoma, and sometimes there's a closed angle emergency, and I'll show you what that is. There's an acute attack of it. So you're walking along and you're just fine, then and all of a sudden you have the most incredible eye pain, and it's not an eyelash and it's not a piece of sand. It's this, okay? You get nausea and vomiting. Your vision obviously blurs. Your head starts to hurt. Rainbow-colored halos. Rainbow-colored, very specific, not like halos around lights before you have a migraine headache. Rainbow-colored. And if you don't get immediate treatment, blind. Blind, okay? It's like, go get it now. And this is, right. So one of the things, and I'll go on a little bit in more detail and show you a picture of that as well. So, why it's so important to have those regular eye exams for glaucoma, you've just heard. African Americans who are the most at risk need to have screening every 3 to 5 years from the ages of 20 to 29. That's how young it can happen. And every 2 to 4 years after age 30. Mexican Americans, because they have a high risk as well, but not as high, obviously should be going more often. And Asian Americans are at higher risk for closed angle, that one with the emergency that can happen. That's pretty scary. And Japanese Americans are at highest risk for low tension glaucoma, where you have normal tension, normal pressure in the eyeball, but you get the glaucoma, central vision, left safe peripheral vision goes away. Okay, routine diagnostic tests. Tonometry is the name of what they call the test when they pull that thing up to your eye to check for eye pressure. Okay, they do it 2 ways. One is with air puff. There's air puff's machine. How many people have had the air puff machine? Okay. How many people have had a machine come up to the eye and there was like no sound, no air puff? That's the applanation machine that actually touches the eye and flattens it. And they see how much pressure presses back. That's why they put in numbing drops before they do these tests. So you don't feel that. And it's considered normal, 10 to 22 millimeters of mercury in the eye as that pressure that comes back in the reading, but most people are 14 to 16. But look at that range, 10 to 22, most people are 14 to 16. Very interesting. Another thing they do is they use ophthalmoscopy. That's where they take the thing in the hand with the bright light and shine it in your eye and do all these weird things with their head while they look around your eye, because they're looking at the structures inside the eye, and it's amazing what you can see in the eye, because they're looking for damage. They also can do something called a visual field or perimetry map, where they actually look at your ability to see moving light at the edge of vision. So someone has you follow a pencil, right? And they say, let me know when it disappears, the tip of the pencil disappears. Maybe for somebody it disappears here instead of here. That tells them a lot. It also can be a means of seeing something progress over time as it gets worse. One of the other tests that's done, it's a special diagnostic test, is called pachymetry. And this is an ultrasonic test where they're looking to see how thick your cornea is. Everybody has different thicknesses of cornea. Who knew, right? People with extra thick corneas, perfectly normal, have higher pressure. They must account for those folks up in the 22 milligram of mercury range, right? And thin people, not thin people, but thin corneas will have lower pressure. Another tool that they use is gonioscopy. And it's only painless after they put the drop in. And they actually put a mirrored lens on your eye to actually see if that angle where the iris meets the cornea is open or closed. And I'm going to show you what closed looks like shortly. And something, not the other one, this is tonography, not tonometry. This one's tonography. Actually measures, and I don't even want to know how they do this one, measures the speed of flow of that aqueous humor out of the eye. Okay, now you're going to get a look at what closed angle looks like. Okay, this is normal. Remember, and the fluid comes out between the iris and the lens, and then around between the lens and the cornea, comes up to the little trabecular meshwork and out through Schlemm's canal. Okay. Well, what if there was something weird going on, whether it was an anatomical defect or an injury or something we don't know, where the fluid comes around, come back, little pointer, there you are, where the fluid comes around in front of the iris and then can't even get to the little trabecular meshwork because the iris impedes its path. That's called closed angle glaucoma, and that's where you have that sudden, sometimes sudden emergency and horrible pain and blindness progressing quickly if you don't get treatment immediately. Okay, so we know already if you've got glaucoma, treatment can prevent vision loss, but whatever damage has occurred is irreversible, and that's the sad part. They have daily eye drops for glaucoma and oral medications people can take, and they work in a variety of ways, as you can see there, everything from lowering eye pressure, reducing the fluid that's already there, or the production of the fluid, and or speeding up the flow somehow. There's laser surgery and conventional surgery. All of those things can work. They may have to go to surgery without the drops. Sometimes the drops stop working over time and then they have to go on. Eye drops, beta blockers, alpha adrenergic inhibitors all reduce the aqueous humor that's produced. Carbonic anhydrase inhibitors reduce the amount of aqueous humor as well. They also can be taken orally. They have pills now for this stuff, not just medicated eye drops. And now they've got prostaglandin analogs, miotics, epinephrine compounds, all to increase the outflow. So how many of you know someone with glaucoma who's using eye drops? Okay, so now you know. You don't know which kind. They can use more than one. It depends on what the ophthalmologist is looking to have happen from the drop. There are a number of side effects of drops: stinging, itching, redness, both of the eye and the skin. People get allergic reactions, obviously, from time to time. There are heart changes that can occur. There's a whole way to take eye drops to actually minimize the amount that gets absorbed by the body and isn't just on the surface of the eye. And there's a technique that they do where you close your eye for 1 to 2 minutes and you actually block your lacrimal gland and so forth. Change in energy level can occur with some of these. Change in breathing for people who already have emphysema or asthma. Xerostomia, and you heard all about xerostomia earlier in the week, I'm sure. Dry mouth, okay. Change in taste for some folks. Headache, blurred vision. Change in eye color. Some of these drops actually make the iris darker. So if you've got brown eyes, you get really, really dark brown eyes. And unfortunately, miotics occasionally, it's rare, but it does occur, can cause detached retina. That's what you see if you've got a partially detached retina. It's not good. And you need treatment so you don't end up permanently that way or become completely blind. And there's a number of treatments you can see on the right, laser surgery, or they freeze it with cryotherapy. Both of those seal the retina back to the eye because it's come off, right? Part of it. It can be done in the office now, which is amazing. In the OR, they do something called a scleral buckle, where they actually sort of literally belt. They put a band around the eye and change the pressure of the eye so it forces the retina to reattach against the back of the eyeball again. Another thing that they do is pneumatic retinopexy, where they put in a glass bubble. You have to hold your eye a certain way for days, your position of your head, and then eventually the bubble disappears, but that bubble is what pushes that retina back to reattach. And there's another procedure called a vitrectomy, where they actually replace the gel that's there and put instead a glass, one of those gas bubbles. So there's a number of things they do now for detached retina treatment. There are a number of trials that are ongoing now for neuroprotective medications, and everything from topical application of things to the surface of the eye to one of the medications that's being used currently for Alzheimer's disease seems to show some promise, but they have a long way to go. Okay, when you have open angle trabeculoplasty, right, where it's able to get around between the iris and the cornea, right, the fluid, so it's open angle, we talked about that, but it's just blocked right there at the trabecular meshwork. And they can do this in the office with one of these wonderful JAG lasers or one of the other ones they have now. 10 to 20 minutes is all it takes, and they just shrink a piece of that trabecular meshwork, which causes other parts of it to stretch, making the opening larger, and then the aqueous humor can come out. That's incredible. And this is what it looks like when they do it. Right, this is the laser beam coming in through the cornea, and in that space between the iris and the cornea, down here to the trabecular meshwork to shrink a part of it. Another thing that they can do is conventional surgeries, just called trabeculectomy, or a filtering procedure, where they actually go in and remove a piece of the sclera and then actually remove after that a piece of that trabecular meshwork that allows the opening to be larger so the fluid can drain better. We talked about that incredible, painful, closed angle emergency that people with closed angle glaucoma can get, and where there is the blockage because the iris space, the space between the iris and the cornea is closed. All right, the pressure you can see builds up on the right, miserable. Well, now they do something called a peripheral iridotomy. What does that sound like to you? They take a laser light and they actually burn a hole right through the iris so that the fluid, because it can't go out through that trabecular meshwork anymore, right? It can't even get there because the iris is in the way because of the closed angle. And so they go ahead and do that, and the pressure gets relieved. And here is the laser coming in right through the iris, making the little hole, and the pressure returns to normal. And the pain goes away. And hopefully it hasn't happened for a long enough period of time. You've gotten care, or your patient's gotten care quickly enough that there's no permanent damage. Okay. Diabetic retinopathy is a sequelae of both, type 1 and type 2. And it's progressive. There is a range. It starts where there's just increased vascular permeability in the retina of the eye, and then it advances to vascular closure, which is not a good thing, as you know. And then there's actual proliferative diabetic retinopathy, where you start growing new blood vessels, or your patient with diabetes starts growing new blood vessels on the retina. And those are, and also on the back of the vitreous gel in front of it, which is not fun either. That new blood vessel network is very friable. It's not like your normal blood vasculature. It's frail. It's your body trying to make up for a starving retina that's not getting enough oxygen because of diabetic angiopathy changes in those blood vessels, okay? So it makes new ones. That's a bad thing when it advances to that stage, because it leaks and you can end up with permanent blindness because of it. You can have macular edema, or a thickened retina that's got some fluid causing swelling of that retinal area, no matter what stage of diabetic retinopathy you've got. It's the most frequent cause of blindness in people between the ages of 20 and 74. And in the first 20 years of having type 1 diabetes, almost all of those young people have this problem. How many have known type 1 diabetes young people who went blind? So there's a couple of us here. And fortunately, you know, there are some therapies now that retard the advancement of the disorder, but it's a real issue. It's been an issue for a long time. As you can see here from the statistics, people who have type 2 are as at risk but not as high. Important things for those individuals: how long they've been diabetic, how well their glycemia is controlled, and of course blood pressure. And this is what diabetic retinopathy looks like. That's tough. It's really tough. Okay, I thought it would be important for you to know, because of the next couple of slides I'm going to show you, and we'll probably start with diabetic retinopathy and not get to macular degeneration until the last hour, so that Dr. Sherman can give his talk on time. Okay, the fundus of the eye is everything you can see inside the eye when you look with the ophthalmoscope, all right? So it's the retina, the optic disc, the macula, posterior pole of the eye, all right? It's the only part of the body where you can see microcirculation. That's incredible. And that's why it's such a good tool in diabetic retinopathy. The optic disc is where the optic nerve comes into the back of the eye. No rods, no cones, it's the blind spot, all right? The macula is the oval yellow spot near the center of the retina. It's got layers of nerve cells. It has a small pit in the center with the largest concentration of cones. This is where your central vision occurs, all right? It also has foveola, which are other areas that are high density with cones. So this is very important. The macula is your central high vision area, okay? We've talked about all of this. Frequent eye exams are important. You can use ophthalmoscopy not only to look at retinal thickening for macular edema, but actually see if there's some of that neovascularization that's so bad with diabetic retinopathy. They do something called ultrasound by microscopy now to look at that as well. And there is fundus photography. And what did we just learn that the fundus was? Everything you can see inside the eyeball. They can actually do that with photography now, and we're going to show you some fundus photos. Here is the eye, and you're looking at this small area right here, okay? And it's got little hemorrhages, so you know there have been little vascular weakenings, some cotton wool spots, and this is when it finally becomes proliferative. Look at all the new vessels. It's the same area almost, but a little bit farther behind. But look at this little network right here, these little thin, friable, nasty looking ones. These are the ones that have to be treated. Okay, aspirin doesn't work. For a long time, there was a myth out there that aspirin would work. It doesn't. They use something called scatter photocoagulation across the retina to get rid of these things. And I'm telling you, we're looking at 1,000 to 2,000 little dots that they make. Vitrectomy, if there's severe bleeding, and that means they go in and they take out some of the blood out of the gel of the eye, because some of these vessels form such a large network and then bleed. And for macular edema, they can actually do a one-spot focal laser treatment to get rid of that. This is what laser photocoagulation is all about, so you can see. Give you a chance to look at that. And the sad news is just because it's been treated once doesn't mean it's not going to grow back. It sometimes does. And it does leave blind spots behind, but it's less severe than what would occur if you did get the treatment. So that's important to know. And this is what it looks like after they do all of those little spots. You can see the little burn marks, all those little white areas in this photo for drawing. Okay. Macular edema, they'll just do the one spot. In this case, they've done a couple, but it's not 1,000. And we're going to skip right here. Mark, what would you like me to do? I did want to make sure that you recognize Jennifer Brackett, Kathleen Kirk, Mark Johnson, and Dr. Statmiller, because these folks really, I can't even begin to tell you the hard work it takes to put in a 40-hour course with the faculty issues alone, and trying to give continuing education credits on top of the students getting their credit. So it's, I'm sure, appreciated by everybody, and I thank them very much as well. Okay, so we're going to finish up with macular degeneration relatively quickly, get on to successful aging, and have you able to leave early. So we know there are all sorts of people who have all sorts of eye conditions. We've certainly reviewed a number of them already. Macular degeneration, though, is the leading cause of blindness in people over 65, and it is age-related. And I thought that actually was a surprise to me. I did not know that macular degeneration was that prominent among the elderly until a couple of years ago when we had someone come and do a presentation for us in one of our summer programs who was an expert in macular degeneration and talked about the research and the hope. And this is one of those disorders that has right now the most promising outlook and is exciting with the kinds of things that they're discovering about this. We talked about when we did terms, fundus, etc., macula. Okay, we know that macular degeneration involves the center of the best visual acuity area. So this is where you're looking at loss of central vision. So what would someone do, one of your older patients who had macular degeneration that was progressing relatively far along and they had no central vision? How would they want to talk to you? Yeah, they're looking at you like this because they can see out of the sides. They can't look at you unless they really want to fake it and they don't care what you look like. But you know, it's a lot better to see what you're looking at. When you look at dry macular degeneration, however, in the eye, you're looking at not only that issue without vascularization, but the macula itself thins. Remember I talked about it as having multiple layers of ganglia? They thin. And it also has these protein deposits, pigment deposits, called drusen that are yellow. And I'll show you a slide of those shortly. It's not, there it is, surely enough. How do you like that? And there they are, right here, these little drusen deposits of this yellow pigmented material that comes from the macula area, which is right here in the eye. Okay. On the other hand, does have these new blood vessel growth areas, and of course it's a concern because 10 to 15% of those that have the dry progress to the wet, and they do leak blood and fluid just like we talked about in diabetic retinopathy, and they have more severe loss of central vision and spots. And there are two types of wet, classic and occult, and here's an example of what it looks like when it starts to proliferate. This is your nice normal macula right here in the center of the retina, and this is what a cross-section through that tissue looks like with lovely vessels underneath, and this is what happens when they start to proliferate and they leak. The classic form is where you can very clearly see the blood vessel growth and scarring that occurs as well underneath the retina, and they call it choroidal neovascularization. Remember that slide I showed you where there was a choroid membrane? And that's obviously the classic form is very severe vision loss. The occult form is not as severe. The new blood vessel growth is not as pronounced, and you don't see as severe an amount of leakage. Things that are risk factors for getting this, of course, are advanced age, smoking, genetics, hello again, hypertension, obesity, and inactivity. Ooh, I hate that. Bad carbs diet, hyperglycemia. Lighter eye color is controversial, but there are enough studies that it's looking like that might be a factor, and if it is, then it plays into the ultraviolet radiation theory. And of course, medical side effects. People who are on phenothiazines, which we mentioned before, right? Mellaril, Haldol, etc., are more likely to be at risk for getting this. This is how you test yourself. You look at an Amsler grid, and the one on the left is normal. It's, you know, graph paper with a black dot that's really a square in the center, and if you have macular degeneration, This is what it looks like if it's wet. It's very severe if it's the wet kind. This is unusual. Sometimes it won't be in the center, it'll just be a little dipping over here, and that's the dry. So the key then in certainly visual health beyond genetics and the things over which you have no control are frequent exams so that things are caught early and caught early in your patients so that you can follow through and make sure that they receive the best attention, the best care, and the maximum amount of impetus to continue living full, vibrant lives without having to go blind. And what we're going to do now is turn this off and go on